If I can just make one comment on Nancy and Leanne's pointing up the sub-Q, I want to just tell you a little bit, 1 minute on the kinetics. When they tell you to take it, I think Nancy talked about not missing out on chocolate or a glass of wine, and that's very meaningful. But you need to know the kinetics of short-acting or subcutaneous octreotide, because that's all we had for 10 years. From 1989 to 1999, we had only the sub-Q and not the long-acting repeatable. So the kinetic is very, very predictable. So when you take a shot of sub-Q, it peaks in 30 minutes, it plateaus for 60 minutes, and half of it's gone in 120 minutes. So when you're going to have or go and have some drinks socially, or you're going to exercise, you take it 30 minutes before you do the event, okay? And then you're peaking for almost 2 hours and you're protected. The other point that Leanne brought up regarding motility and the rapid motility, subcutaneous octreotide works beautifully if you have the eating pattern diarrhea that Leanne talked about. And that is 30 to 60 minutes after you eat, you're guaranteed to have a bowel movement. If you take sub-Q 30 minutes before you eat, it actually physiologically slows the bowel motility down. That's one of the natural actions of native somatostatin, and octreotide mimics that in spades. So by taking a shot of sub-Q 30 minutes before you eat, your bowel is slowed down for almost 2 hours. It doesn't affect emptying that much, but it's slow enough to maybe help you digest your enzymes, or to get the enzymes in and have it break down the fat. So that would be, and I totally agree with their discussion of the use of sub-Q, and it's good for you to know the kinetic. So 30 minutes, it probably starts working faster, but it peaks in 30, plateaus for 60, half of it's gone in 120 minutes. So if you take more initially, it lasts longer through the day.
Okay, thank you. We're missing Dr. Warner yet. I don't know. Oh, no, that's not him. That's why. Is Cindy here? Cindy? Can somebody just kind of retrieve him, and we'll do that. Couple of questions. Okay, first of all, how many of you got the email confirming your registration, that you were registered? Okay, somebody actually asked me, do I actually use crayons? And the answer is yes. If you remember my email, it said that you had to bring a pen. Crayon is all I'm allowed. That's about right. I'm allowed crayons. And yes, I have the crayons to prove it, just in case you're wondering. The other question somebody gave me is, where did I get the vest? This was from Peter Blake, who is a patient who passed away this past year. A great, great guy. I wear it for him, but I also wear it in deference to Will Smith. I make this look good. Okay, so that's enough of my humor for the day.
Another thing I could say, the 3 metabolic disturbances that you get with octreotide were brought up, excellent points. Talk about the thyroid. So somatostatin inhibits growth hormone and the hormone that controls the thyroid. That's its natural mechanism. So octreotide and lanreotide will do the same thing. What you need to remember about the thyroid function tests that measure your active hormone is that most doctors don't order the free T3. They order the TSH, and the TSH is the hormone that's affected by octreotide or lanreotide. The hormone that causes you to feel overactive or underactive is the free unbound T3. That's called thyroid 3 or triiodothyronine. So when you have your thyroid function tests tested, you need TSH, free T4, and the free T3, because 2/3 of the time only the free T3 is low, and that's the one that you need to replace with levothyroxine. The second point brought up was glucose intolerance, and it's really, I can give you the exact number. Diabetes is defined as greater than 6.5% hemoglobin A1C. 90% of my patients that don't have diabetes, that aren't predilected for diabetes, will raise their hemoglobin A1C modestly. from 5.8, which is normal, to maybe 6.2 or 6.3%. You don't need to treat that. You don't do anything. It's not diabetes. And that's what octreotide or lanreotide does. It does not cause, in my experience of many moons, does not cause diabetes. The third point is the fat malabsorption that was also brought up by Leanne and others. And when you have fat malabsorption, you run the risk of not having the absorption of the fat-soluble vitamins, which are vitamin A, E, D, and particularly D, and K. So you end up with a value of vitamin D in your blood that's usually very low after you've been on octreotide. Whether you have full-blown or partially blown fat malabsorption, you're malabsorbing fat. And when that happens, you can't absorb vitamin D. Now, you need vitamin D for one thing, to allow calcium to get into the intestine. Plain and simple. That's what vitamin D does when you take it. You know, going out and opening your mouth and standing in the sun won't do it, because when you're in latitudes that are sun latitudes that don't show, but when you reach the magic decade of 50, your skin does not convert to 7-hydroxycholecalciferol. You need it from a bottle, okay? And the bottle should be about 2,000 to 4,000 units. You pop a pancreatic enzyme at supper time. You eat the enzyme, and then you take your vitamin D, and that'll help you allow the absorption of vitamin D, which occurs in the just after the duodenum in the jejunum. And then you need calcium citrate, not calcium carbonate. Calcium citrate you need because it's ionized calcium, and it comes in a ready-made form to be absorbed. Calcium carbonate does everything that it shouldn't do, namely it neutralizes the acid, it keeps calcium in a neutral zone, and you can't absorb the calcium. You got to eat 10 times as much Tums as you do calcium citrate, because calcium citrate comes in an acid form that absorbs. So you need calcium citrate and vitamin D, and you should be on 2,000 to 4,000 units of vitamin D daily if you're on octreotide or lanreotide.
Okay, I'm going to start off real quick with something that, how do I describe this? It can be interesting, but I'm going to open this up first. Does anyone on our expert panel have a question that they would like to ask?
I would ask Dr. Odoricio to comment on the use of the test for neuron-specific enolase. What is his view on that?
So you've all heard the question. Neuron-specific enolase, in actual fact, the cell that I showed you was a gift from Dr. Qualman, was stained with neuron-specific enolase. It was probably the first stain that was specific for neuroendocrine cells right after silver staining. If you go back into the old literature, Mason and that group did silver staining and showed the granules of these neuroendocrine cells that give them their identity. NSE was the first. You can measure, and some of you may be getting NSE in the blood, neuron-specific enolase. The problem by all pathologists that know anything is that if you try to measure it in the blood, it's non-specific. That means protein can interfere with it and give you a false elevation by assay. The pathologists that use it say the same thing. It's non-specific because they stain tissues that were not neuroendocrine cells, and they stain positive. So you're much better served with the stain for chromogranin A and especially synaptophysin. Those two enzymes are the enzymes that give the identity of the neuroendocrine cell, and Dr. Warner brought that up beautifully, that a neuroendocrine cell has components of both neuronal kind of transmission tissue as well as the endocrine aspect. Endocrine just means blood-borne. It doesn't go by way of a canal or a duct like a ureter or anything like that. It drips right into the blood and most often acts like a hormone where it goes to another tissue to exert its action. So I would say NSC, and they're still talking about it, but we don't measure it. Our pathologists don't stain for it at all, and we don't measure it in the blood because you have other better markers in the blood, pancreastatin, chromogranin A, neurokinin A, serotonin. Serotonin's not a peptide. It's a it's a peptide. One amino acid. It's a single protein, and that's very accurately measured now.
Sure, Dr. Zaks, go
Yeah, I
ahead.
have a question for Tom. Could you make any comments guiding us in the use of testing for neurokinin A?
It's a great question. We talk about neurokinin A as it's absolute. If you ask me, in all the folks that I routinely measure neurokinin A on every visit, 6 months or a year, what percent of my patients may have an elevated, or what percent of my patients will become over 50, I would say it's small in my experience. Now, Dr. Woldering may have a different view and a different set of folks that go down. But for the most part, if they start out under 50, they stay under 50. The exception is the group that as they go along, they start to show mild progression of their tumor. And their tumor may be removed. That's one thing about neurokinin A. You can take the tumor out of the bowel, but you can't take the neurokinin A out of the bowel. In other words, if it is a true marker of some sort or a signal, without even the primary tumor being there, the neurokinin A can move and it can increase. And the good news, remember, it's not hopeless. It just means you've got to do something to try and bring it down below 50. Because Ardil showed this at Belfast. She was the first to point up the neurokinin A value. She said, you take the 50 and you bring it, or over 50 and you bring it down, it takes the same probability then. It puts you back in the same probability of survival. In terms of which one folks are going to do it, I think the ones that can be expected to be high neurokinin A on first visit are those that are showing CT progression by more than one scan prospectively. So 2 or 3 scans showing slow progression, you'll start to see the neurokinin A change. I think that's the best I can do.
And I just want to make one more comment. If you think that those of us who talked about the team approach are the only ones who are doing it, just Google Tom and Sue Odoricio and look at their team members and the expansive list, and then you'll see what a real team effort is.
Thank you. Thank you. And that obtains, in the groups and the centers like Mount Sinai, Moffitt, LSU. But I do think we have a group of folks that, as I said earlier, different disciplines that think about this. You need folks that are thinking about the entity. Many medical oncologists, they see different types of aggressive cancer, and they're very appreciative, for the most part, of people who think about neuroendocrine tumors and can help guide them, because you don't need the same pace of following with a neuroendocrine tumor as you do with the other cancers that they're used to taking care of. And so that's an important point in terms of radiation that you receive, how often you get CT scans. MRs become very valuable for liver burden, and so on and so forth. But I appreciate Dr. Sachs's comment.
Anybody else? No? Oh, come on.
Wait, I have a question. I have a question for the audience. I'm always trying to improve what I do. Was the information provided to you helpful in the nutrition area today? Good. Thank you. All right, not to get a brag, but what would you do differently? What would I do to help you more if someone were to give me money? And sometimes pharmaceutical company offers some educational time and money. We know that. What would you do? But if y'all would leave even those ideas, or write down an idea that you have and leave it for me, that would be real helpful, because I develop material for y'all on a big scale. And I want to make sure that what we're doing and providing through companies that have the funding for us, that we're providing you what you need. And I will tell you, too, if there's more cards of the recipes, we had plenty left out to take them. But anyway, that's my clue, my idea. I want to make sure that what we're doing as educators, we are educators, and that we're hitting the needs of our patients. So that's my question is, and you don't have to answer out loud, but if you'll write me a note and just put down, this would be helpful, short of me writing you 2-3 weeks of menus, because that's very time, and it's very hard to do. But other little ideas that will help, I'd appreciate it. Thank you.
And I can't tell you, I mean, hearing Leanne, we used to hear Monica Warner all the time, and she, and I think more so even than Bill Go, and he's a master nutrition person, gastroenterologist, but Monica was, wouldn't you agree, Monica was a premier nutritionist, and hearing Leanne was very rich and informative for me today.
By the way, if I'm going to comment real quick, you mentioned Bill Go. Just to give you an idea of the circles that these people run in, Bill Go is one of the 12 or 13 people who designed the food pyramid, that USDA thing with all that. He's one of the guys who designed that. So this is the level of people that these guys talk to and work with and get their information from and whatnot. All right, I'm going to move along with some questions here. Little liver involvement, no syndrome. That's important here. Are there cases of NETs in the small bowel in which octreotide or lanreotide would not be recommended? No syndrome, but they're not mentioning any other symptoms if there are any.
The FDA approval of octreotide is for the symptoms of carcinoid syndrome. The FDA approval for lanreotide, somatulin, is to deter growth of the tumor and prolong survival. And therefore, by extension, and because it's recently been shown that octreotide also prolongs survival, I would be inclined to use it in the absence of carcinoid syndrome for its growth inhibiting effects.
And just to add, go ahead, you go.
No, I was going to ask both of you, if you imaged and there was no evidence of receptors, would you still use it?
So, and that's where I was just going. That's why the power of that stain on your tumor is so important. In fact, just last week I used that argument, and the reason why I say I concur with Dr. Warner's thoughts, because Mayo Clinic has a philosophy, or had a philosophy up until a year or so ago. I don't know if they've changed it now in light of the lanreotide data and the indication, but they would say to a patient with a non-symptomatic carcinoid to the liver, unless the liver tumors increase, we won't start octreotide. And that they've held tight on. They've taken a patient that's had liver disease by CT scan that were stable, and they just said, leave it alone until you show progression. Now, up until this anti-proliferative indication, maybe that could be justified. But you know, and I do agree also with Dr. Sachs. I think if you have a functional scan that's not showing anything, I still think you've got to do the staining, because that's the anatomical proof that you have the receptors. One other thing that was talked about a lot today was the action of octreotide and lanreotide on the tumor cell itself. It slows its progression. It slows the release of hormone. But you got to go back to the native somatostatin. There were 4,000 papers written in a period of about 7 years from the time somatostatin was discovered, but it has a second action. It also blocks the action of the hormone on the target cell. So now you've got two mechanisms. So if a patient is symptomatic and do not show receptors, but is symptomatic, that's, as Dr. Warner said, the first indication for octreotide was for symptom control of diarrhea from carcinoid, and for the very erotica et exotica tumor called watery diarrhea syndrome, VIP secreting tumors. That's a life-threatening kind of diarrhea due to a tumor. And in both cases, those were the indication for octreotide. So it does block the target tissue of a hormone from the tumor as well as the tumor itself.
As I said before, even in the absence of a positive octreoscan, which depends upon the receptors, the prolonged survival or progression-free survival was effectively prolonged
Yes.
by octreotide and lanreotide, so that it works in that effect against tumor, regardless of whether there's receptors or not.
And that's an epiphany. That's true. That was in just what Dr. Warner picked up in that lanreotide paper. They said positive. They had a table, positive or negative. You had the same effect, which was remarkable. I got to go back and think. Could it be that there were some, receptors of the tumors were small and couldn't be seen? I don't know. But that is a very important argument for the use of either or, because they really look. You saw them upside. You turn those two upside down, they're the same, except different companies. And for the most part, they have the same. They have the same action. Lanreotide has a little more action on the receptor 5 than octreotide.
Okay, for Doctors Odorizio and Dr. Warner, how many centers in the U.S. do you consider to be true centers of excellence today, and what are they?
Well,
Ask your support group. You can get a real good answer there.
Yeah, that's where to go. But certainly Mount Sinai, Moffitt, LSU, and LSU emphasizes extreme surgery, very careful debulking kind of surgery. Moffitt has a medical oncology kind of orientation, excellent. Richard has, and Dr. Sachs have the all-purpose. They look at everything in terms of therapeutic options, and ours look at multiple options. Ed Wolin, when he stops going from place to place, I think he's in Montefiore now. He's on your side.
He's not there yet.
He's okay.
He's due in February.
A sighting says he's due in February. He was the one at Cedars-Sinai, and he's marvelous. He's a marvelous physician and neuroendocrine medical oncologist. I want to say Arthur Vinnick. Arthur in Norfolk, though, kind of splits his head. He does diabetic neuropathy better than anybody in the world, and probably knows more about neuroendocrine tumors not next to even Dr. Warner, but he's had a great deal of experience with the neuroendocrine tumors in Norfolk. I don't know how many folks he takes down there, though.
Did you forget University of Iowa?
And your own
It's hard to be humble, let me tell you. Yeah, by God.
We'll just send him to Michigan State.
MD Anderson.
And MD Anderson with, now again, there's a little caveat with James Yao at MD Anderson, because he's very driven by clinical trials, which is very, very good, but it's hard to get into them directly if you don't qualify at the get-go for a trial study. And so I've had several of his folks come this way because they didn't qualify at the front for the clinical trial. So I think James himself, James Yao, may screen for clinical trials first. So that's one caveat about MD. But you should call. You should try and call down there. I think Richard's right. It's a great place. And pardon? And Matthew Koke, Dana-Farber, thank you very much. Matthew is at Dana-Farber, and he's a medical oncologist, a very thoughtful person, as well as a neuroendocrine kind of specialty person. He's the one that headed up the Telotrestat in the United States, and he's the one that's really been the thought leader in terms of the study design of the Telotrestat that we heard about, the serotonin synthesis inhibitor. Very good.
By the way, Matt Kolke, as a sidelight, used to speak at many of the Carcinoid Cancer Foundation lectures at Mount Sinai, and all of the women just thought he was really easy on the eyes. So, for whatever that. All right, Leanne. Eric Liu?
So Eric is now in Denver. He's not. Eric works in oh my God, Rocky Mountain Cancer Centers. There are 5 of them in Colorado. I think he's working with a superb Nutting. His name is Nutting, a superb interventional radiologist, and he is active in the carcinoid, seeing patients again. He relocated from Vanderbilt, and he's been there. And as I understand it, he's taking folks. He's close to University of Colorado. I understand from him that he's not really affiliated with the University of Colorado. There is a guy there named Tom. He's a medical oncologist, and I'll think of his last name in a moment, but there is a medical oncologist there that's building a program in Colorado, University of Colorado. But yes, Eric, that's a great one. Yeah, Eric is very, very thoughtful and thinks beyond the surgical therapies.
And if you don't know who Dr. Lou is, you can watch his video when he lectured in New Jersey 2 years ago. Was it 2 years ago? Okay.
Watch me dancing with him on the YouTube.
There you
in Canada.
Oh, this could be stories out of school. All right, for Leanne, it seems that regular soda, with not the diet kind, helps ease the pain in my stomach when I get an attack. Is it okay to use soda to calm my stomach pain, or is the sugar uptake a concern for NET patients?
Well, are you having dumping right behind it is the first thing. If you're going to the bathroom right behind it, even if it calms your stomach, then no, we don't want you to use it. The sugar's bothering you. Carbonation can bother you and cause more gas. But I do see some people that really do feel like I don't know if it causes them to burp up a little bit of the gas in their stomachs, that say it's helpful. But if the sign is, are you going to have you're having a rapid emptying of your stomach after you take that cold drink. Sugar itself does not cause these tumors to grow, so I don't want that to be an issue. The issue with sugar is it increases your symptoms of diarrhea and sometimes a little bit of hyperglycemic in a diabetic.
And she brought up dumping. Dumping is this phenomenon where sometimes the valve in the stomach to the small intestine is interrupted, and you can get food, instead of storing for a short period of time in the stomach, rapidly empties into the duodenum. And if there's a lot of simple sugar, you raise the insulin acutely, and within sometimes 15 to 20 minutes or more than an hour and a half later, you get this severe drop in blood sugar. That's called hypoglycemia. And once again, if you have that phenomena by history, Octreotide works very well 30 minutes before you dump. And so that's, you can take it before a meal.
I would add to that every patient who has the problem of dumping should take a rescue injection of short-acting Octreotide before any big meal that they consider might put them at risk. And they should almost always expect to be protected against that symptom.
That's a superb point. As an empiric use of it, I think excellent, yeah.
Okay, is the flushing associated with carcinoid syndrome typically experienced as a hot or cold sensation, or does that vary?
It's a hot sensation and a dry flush. That's the important consideration. Carcinoid is not a wet flush, whereas a menopausal flush is a moist one. And there may be sweating after the flush, but the flush at onset is absolutely dry in carcinoid.
Predominant. It's very interesting, not interesting, but important to me, because I'll see folks who may get a bit upset, or not upset, but somewhat emotional during an interview, and they'll start to turn red or flush, and I may stop and say, "Are you aware of this?" And many are. They can feel the warmness or feel internal warmness, but sometimes they say no, that my partner will tell me if I'm flushing, but like Richard said, there's usually no perspiration. It's a dry flush.
Okay, for Dr. Odoricio, since you already have the microphone, I've heard that there's an issue with vitamin D3 in patients who are taking somatostatin analogs. Is this true?
Yes, and that's one of the maladies. D3 is the you get ergocalciferol or cholecalciferol. One's vegetable vitamin D, the other is, I think, human or animal vitamin D. But those are ergocalciferol, cholecalciferol, and it doesn't matter. Both forms they're called D3 or D2. But and the vitamin D that you get that you really need is the stuff you get over the counter. And it is true with lanreotide or octreotide, and the mechanism is, as Leanne talked about, and that is that you suppress the pancreatic enzymes prandially. So when you eat and you're on octreotide or lanreotide, and you start to eat, your pancreatic enzymes, especially as we heard lipase, does not release. So now you have no enzymes going down to meet the fat from your meal. And that starts the creativity, and Dr. Warner's so experienced and expert in this, but you can't break the fat down. And because vitamin D is fat soluble, it means it needs to be in that kind of form for the enzymes to break it down to be absorbed. That's the issue. And so what I say is, and in terms of the enzymes that you take, some people get away with just papaya chewables over the counter. Walmart makes them. But like Leanne said, there's not a lot of enzyme in it, but people taking 5 or 6 of those have enough enzymes to do the job for them. And then there's vegetables. There's actually kosher vegetable enzymes. It's called Digest Gold. And it's a vegetable enzyme that works pretty well in some people. I tend to use Zenpep or Creon. And there's one other enzyme that you can get over the counter. GNC makes one called pancreatin, pancreatin. You can buy those over the counter. But they're all digestive enzymes. They're all designed to break fat down. And the reason vitamin D will drop in you is because you can't absorb it. Go ahead, you go with that.
I just wanted to comment about vitamin D. We do a vitamin D level in every single patient, and we monitor it. And it should be kept in the low normal range between, let's say, 30 and 40. It's not advisable to take more than is necessary to keep it in the low normal range. On the other hand, if it's below 30, you need more vitamin D. And so it's easy to regulate vitamin D in any given patient.
That's a very important point.
Can you hear me? There is one vitamin on the market made for, it was put out for cystic fibrosis, where we really have tremendous amount of fat malabsorption, and it is called Aqua, ADEK, and it is available, and it is a fat-soluble vitamin that's put on a water molecule, and it'll cross over.
Is it all 3 of the fats? ADEK?
It's all of them.
In there?
Yeah,
Oh,
all 4 of them.
Aqua.
Aqua, ADEK. And it's been on the market for a good while. We used to have 2 on the market, and now that's the only one we have.
Is that it's
Prescribed, because we want to monitor. I think you could get, actually it's not, I should take that back. Zenpep is one of our companies for pancreatic enzymes, and if we give you the order for the Zenpep, they have a patient support group, patient support discount or program that will give you a discount on your Zenpep, but it also will send you free some of the formulas that you may need, and they'll also send you free that ADEK, and they'll send you another D. But you want your doctor to know what you're doing. So never take them without monitoring, because like he said, we don't want that vitamin D to go higher than it needs to as well. So, but there is another product that is available.
I'm waiting for prescription for vitamin ETOH. Okay, so, okay. Nancy mentioned the importance of having family members get screened for carcinoid. Will insurance always cover the tests? And another question that ties in with that is, what tests are being done for the familial studies that they're finding these people?
The one I use empirically, and you see what is serotonin. I mean, assuming that the most common tumor is the midgut, and as Richard said, their midguts past midgut, or small bowel, small bowel, small bowel. I think the serotonin is probably the most sensitive, certainly not the most specific, but is a sensitive test. But that's a great question because I'm not sure what you have to.
You don't have a lot, but you have knowledge that there are families, and to have a frank discussion with your physician with knowledge of the signs and symptoms of small bowel carcinoid is important for follow-up. As you said, there are no specific tests that we really have to screen these patients. There's no good screening test. But I think the awareness is really important because it allows them to rethink maybe some symptoms that they've not regarded as significant and receive, proper medical evaluation.
The new familial carcinoid studies that I told you about that were reported in July from the National Cancer Institute indicated a mutant gene which they had an analysis for, but that's strictly an experimental study, and that type of analysis is not generally available. If this study proves to hold up as time goes by, I'm sure that analysis will then end up becoming more commonplace. But for now, there is no specific blood test that can be, or chemical test that can be done to ferret out familial carcinoid from sporadic carcinoid. We just have to test for carcinoid in general by the usual tests such as serotonin blood level.
I just want to underline that and comment how wonderful it would be if you screened early enough before it had a chance to do any significant damage.
Okay, two questions pretty much the same. Is it safe to take Prozac and SSRI if you have stage 3 neuroendocrine cancer?
It doesn't matter what stage you're in. If you don't have very high blood serotonin levels and marked symptoms of carcinoid syndrome, it's safe to take SRI.
Yeah, and that's an important point. And I know the philosophy from Moffitt goes back a long time with the SSRIs. And the other thing to recall, Prozac and Zoloft are really quite high in the concentration of SSRIs. And in fact, there's at least 2 papers of carcinoid crisis in carcinoid syndrome, active carcinoid syndrome patients. But as Richard said, these people are running high blood levels of maybe over 1,000, 1,500. These people are already primed with high serotonin, and you can raise peripheral serotonin a little bit. But as Nancy noted and Richard noted, I think you're reasonably safe. You're taking octreotide, so that's another protective mechanism when you're taking an SSRI, and the benefit outweighs the risk, I think. And you can take SSRIs that don't have, like Effexor, I think, is a lower concentration. So you ask your doc for lower concentrations of the SSRI in the pills, and you should be okay, as Richard said.
Remeron is also a very safe, effective antidepressant.
Yeah, that's very good.
Okay, should we be more concerned with progression-free survival or survival?
Well, there is something called overall survival, and that is different than progression-free, because progression-free simply means no signs of tumor growth or progression up to that time, but there can be continued life for a long time after progression first manifests.
I really agree. In fact, I say to my people, I don't talk about OS or overall survival that Richard mentioned. You really take you take the schema and you see the time to progression or progression-free survival there, and you add those boxes up. And they come out for the most part in years. And then you know that they're not mutually excluded boxes, that you haven't lost a therapy, by doing another therapy. That's the art. the very important art of being able to move among the boxes of therapeutic modalities without losing one on in the process of doing another. And you keep adding those up, and you come with a long span of progressive-free disease. And overall survival really does not have meaning for myself personally, and I don't use it, I don't talk about it, I don't understand that. When you're talking years.
Okay, for Nancy, if Sando was less effective 1 month, could it be because of difficulty in administration, such as the local clinic may not do it as often, or it clumped, or something like that?
Yes. It can be administered incorrectly, preferably deep intramuscularly. It can be because it was not mixed properly, or they didn't draw it all up into the syringe. It can also be that during that month your disease is more biochemically active than a month before, or you may have been exposed to more triggers than you were the month before. It could be because the batch was not as good as it was a month before. They keep tracks of that, and some patients have very little response and they find out there are bad batches. So there are a variety of reasons, and yes, that is true.
Yeah.
I'm going to clue you with one other thing now, and let you talk longer. Breakthrough shots, what are those?
I feel very primed here. Breakthrough shots are when you are on a long-acting and you're going to encounter a situation that may require more of the somatostatin analogs, such as diet, exercise, stress, illness, and that if you can anticipate it, you can proactively mediate it or prevent it with the rescue shots, or you can recover from it very quickly with rescue shots.
That's so important, because when you take a shot of long-acting repeatable octreotide or 2 or 3 shots of lanreotide, and there is a slight difference in the kinetics, and I'll say that, that level has no brain. It doesn't know when you're going to encounter stress, emotion, excitement, glass of alcohol. It just doesn't know that level, and you do need, that's why they call the sub-Q now rescue. It is the breakthrough, if you will. I always ask the question, is more octreotide better? And you have to ask that with lanreotide. You use octreotide sub-Q because lanreotide used to make a sub-Q, but they don't. They don't have a fast-acting now, so they rely on the octreotide sub-Q. And the question always is, when you hear stories of people breaking through or needing a shot at 3 weeks instead of 4 weeks, the question remains, is more better? And you use that rescue, you use that sub-Q, you become a veritable pro in using that rescue, because when you use it, you'll know that it'll help you when you have the response or not.
One last thing I'd like to say is, when I'm seeing patients back before their injection, I ask them, how are you doing on the drug? And majority of the time people are ecstatic because they are getting control of something that has been very problematic. But what's important for us to hear, in order to know when to increase a dose or decrease or increase the frequency that you receive a drug, is how your symptoms while on the drug manifest. If you have symptoms of breakthrough on and off throughout the cycle of the month, then you probably need a higher dose. If you notice that you have symptoms at the last week of the month, then you probably need to receive the drug more frequently.
Like every 3 weeks.
I want to talk about the elephant in the room, and that is, what about if a patient is running out of money and they need more of these, either somatostatin or lanreotide? Are there avenues that they can pursue?
Yes. Again, this is where your nurse is very important, or your social worker, because the drug companies have patient assistance programs to help patients obtain the drug. And for the rescue shots, the drug representatives often give us cards to sign for samples. and we can provide a sample to try to see if this indeed helps. It gives us an idea of how best to manage you. So through the drug companies, there are programs that can allow you to obtain this,
Yes.
long and short acting.
And just one difference, as you probably are aware if you're taking lanreotide. So when you take the octreotide long-acting repeatable, that's a IM injection, and usually it's the 2 areas in the small squared areas on the buttock. When you take lanreotide depot, it's deep sub-Q. So that in fact, before the FDA approved it, caregivers could give it at home, the shot, and then the FDA said no, that had to be given.
Right, that's the conundrum here, is because I've been prescribing it for acromegaly forever, and my acromegaly patients take it home with them and they self-administer. And I think part of the problem, and this is not clear in the product insert, is that with the oncology perspective, like Medicare will not cover it unless it is administered by a nurse.
That's right.
But if you have a mechanism of obtaining the drug, like many patients do through other prescriptive plans, and they can get it, this is a off-label way of utilizing it, is to self-admit, but people do it.
Well, and I think Ipsen has, it's a Tersica Ipsen, but Ipsen has a visiting nurse service, is that correct?
So does
Sandostatin.
Sandostatin.
Sandostatin will do it too. They'll come and give you the shot.
It's not covered by Medicare.
Gotcha.
Or Medicaid.
Okay. The other difference, and some people like it more, the lanreotide it's a square wave. It's like Lantus insulin. When you take Lantus, which is the long-acting form of insulin, it goes up at one level and it stays the same level theoretically for 24 hours with Lantus. Lanreotide is the identical kinetic. It goes up to the dose that you gave, and it's a steady level. There's no peak and trough like there is. There's actually a peak and a trough with octreotide LAR. And some people feel that shot when they take octreotide for the first 12 hours. You have a massive release of octreotide, and people can get hypoglycemic during that time because it knocks down one of the hormones that counter-regulate insulin, leading to hypoglycemia. So on those days of the people that have that kind of feeling of being washed out for 24 hours with octreotide, I do give them the 4 Ps, pizza, pasta, potatoes, and pastry, for 24 hours, so they don't run into that drop in sugar. But that's a big difference in terms of the kinetic. On the other side of the coin, octreotide is very predictable when it's out of your bloodstream. So if you hold the next shot for the month, at 5 weeks, for the most part, 95% of the patients have their levels down to where you can do diagnostic testing right now. Lanreotide is trickier because it seems to permeate everything in the body, and it doesn't clear in a predictable way. So we wait sometimes as long as 8 weeks. Had a person who was given 120 milligrams of depot lanreotide for 6 months, it took 7 months for it to clear out of his bloodstream. And we measured blood levels. So number one, 120 milligrams twice a month is huge dose for lanreotide. But the physician gave it to him because he felt he needed it. But when we went to do diagnostic testing, we couldn't do it because he had so much in his bloodstream left. So lanreotide doesn't decay, doesn't leave your body as predictably as the octreotide LAR. That's the only other caveat. Many people, like I say, like that smooth, steady level of lanreotide, and so we do switch folks. And the inconvenience of with deep sub-Q, you can give it in at least a couple places. You can give it the anterior thigh, you can give it in the soft fat above the muscle, and that's more sites where you don't. But don't forget, you can still get granulomas from the lanreotide in the sub-Q. So when you say, is it difficult to put in, sometimes putting octreotide LAR after 2 years is like going through the knot of a tree, because those granulomas are so hard that you wonder how much absorption you're getting. And you only have 2 sites. They alternate buttocks, as you probably know. And after a while, those, you can't take enough zits baths to soften those things up. I mean,
Okay, support group tip on that. If you're doing the daily breakthrough shots or rescue shots, at least in New Jersey, when you get the prescription for the medication, make sure you get the separate prescription for the syringes and needles because they're a different item. For Dr. Odorizio, is PRRNT available yet, and what's the difference between PRRT and PRRNT?
so
Are they
the
same?
N makes the difference. Richard Baum, so it's peptide, which is the form of octreotide, receptor, which is the membrane receptor 2 that you've heard all about it. Radionuclide, radio-nuclide is what you give. Is it going to be yttrium-90 or is it lutetium? And the T is the therapy. It was also called PRRT, and now the sophisticates call it PRRNT. How's your PRRNT program going? That kind of thing. But then, in terms of what's available in the United States, XL Diagnostics, Abe Delpassant has a business. He's been in the business 23 years in nuclear medicine. He was at MD Anderson for 18 and then started his own business. He started with indium-111 PRRNT, high-dose indium for treatment, and then was able to get the lutetium from the same group that's doing the Lutathera study. So it's the same compound, lutetium dotatate, a modified octreotide, that he's using. And recently he had to go down because he told the FDA, I want to do 150 patients with PRRNT with lutetium. He did it. Then he went back to the FDA and said, I was really not being sincere enough. I want to do 250 patients. And they said, time out. You have to now reapply, which he did, and which was approved again. So now he's back doing it. He does 4 treatments, 200 millicuries each. Of the 6 weeks, 6 to 8 weeks apart, and he's very, very, very good. He's got a little cartel now of medical oncology. It is not affiliated with MD Anderson. He goes to a different hospital if the patients need to have a hospitalization. It's in Houston, Texas. So that's the only place outside that I'm aware of outside of Iowa, and we are the providers now for the yttrium-90 DOTA TOC. DOTA is the cage, TOC is the form of octreotide. So right now we're the only people doing the yttrium-90 in the United States. It's very slow, unfortunately, because we do dosimetry on every first treatment so that every patient gets their second and third treatment is modified. So we customize the amount of radiation that it's never been done. It's never been done in Europe, and it hasn't been done by XL. And it's very important because we're finding out that a 100-pound person getting the same dose as a 250-pound person may be worlds apart in terms of how much radiation goes to the kidney or to the marrow. And it's very important that this be customized per patient. So we're doing the right thing, we believe, and we hope we can condense it down so everybody gets a dosimetry after their first dose. But having said that, it's still very slow for us. We hope to increase 2 more protocols over the next 4 months. But right now in the United States, it's XL Diagnostics. It's Abe Delpassant. You can Google it, and it'll come right up, and you can talk. The nurse, the charge nurse, research nurse, her name is Miss Cork, C-O-R-K, and they're very, very accommodating there. But it's a fee-for-service type of thing. But they are trying to get recovery from Medicare and for insurers down there for coverage.
Leanne, what are your recommendations for alcohol consumption for carcinoid patients?
I'm from New Orleans. I think everybody ought to know. You're gonna have if you're going to drink, follow these guys. They have taught half of my support group up in New York how to do this successfully. I get tickled with Mary Ann. Alcohol is going to cause symptoms of flushing if you are having syndrome, so that's concerning. It's probably the worst one, I think. And so if you're not doing short acting, you're probably going to have some symptoms with it if you're symptomatic. Let's go outside of carcinoid just a second. I do a lot of cancer screening initiatives. Breast cancer is related to alcohol consumption. Recommendations are for 1 drink a day. for females and 2 for males. So we do have some link between other cancers and alcohol, so I don't want to just say something across the board for that and leave off my big picture. All alcohol ought to be done within the limitations of health and healthy lifestyle. So with that being said, if you're going to have an alcoholic beverage and if you've had your gallbladder out, let's take out carcinoid. Okay, if you don't have a gallbladder, you're not going to digest or do well with alcohol usually, and very uncontrolled, very fast bowel movements, and which kind of can bring a whole downer on your alcohol consumption if you stay in the bathroom. So so there's many things that are outside of just carcinoid itself that involve alcohol and problems with alcohol in my patients that I'm taking care of. So if you are and you're doing the short acting, these guys are really great about telling you exactly how to do it, because when we have the group, we have a support group every 3 years in New Orleans, and they can teach everybody how to go out on Bourbon Street if they're just real careful. So I know it can be done, but I kind of go to the other end because of the gallbladder issues and just poor tolerance overall.
But again, there was, and Richard may remember, Jerome Feldman from Duke University. He had what he called the port wine test. He had folks with active carcinoid come from all over the country, and he would bring them into a little metabolic room. He'd sit them down, he'd take a little 4-ounce glass, and he'd pour this special kind of port wine, okay? And he'd pour it, and then he'd turn on his little timer, and he'd have them take a sip. And he determined that usually folks that had active syndrome with the high serotonins, it would release a massive flush within 15 to 20 seconds of just a single sip. He called it the port wine stimulation test. But as Leanne said, it's one of the E's that mediate the release of serotonin, and it's probably by way of an adrenergic or adrenaline type of mediation. So any of the E's, exercise, emotion, excitability, ethanol, ephedrine, decongestants. People take decongestants if they have high serotonin, can precipitate carcinoid flush pretty dramatically.
Also, when you go to the dentist.
Yes,
When
absolutely.
you have Novocaine.
That's very important. They give
Yeah.
you epinephrine, they'll give you a shot to keep your vessels from bleeding. And I've had dental people, dentists call.
Yeah.
And say, what do we do with these patients?
There is a numbing product that does not have epinephrine in
Yes.
it, and that all dentists have it. The only drawback is that you might have to have repeated doses if you're having extended dental work done.
Excellent point. And so I always tell patients to take a syringe of, the sub-Q with them, and to try and take it 20 minutes before they have the shot. But even that can be overridden.
Okay, for Dr. Zaks, can carcinoid heart disease suddenly appear from a scan 3 months ago? PNET's the primary.
Could you ask that again?
That's what I have. Can carcinoid heart disease suddenly appear from a scan 3 months ago? PNET primary.
I think that the major determinant is usually the serotonin level. Now, in terms of how rapidly it could appear, it can appear fairly rapidly. In our study, of course, I'm looking at patients who have carcinoid heart disease and have to consider open heart surgery. We did a study of all patients who underwent open heart surgery and showed that 46% of those who received tissue valves developed recurrence on those tissue valves, and we've documented it as early as 4 months. Others have documented it as early as 3 months after the new valves were put in. Can you imagine how rapidly that serotonin effect is?
You said, if I heard you correctly, PNET primary. That means a pancreatic neuroendocrine tumor, which almost never is a serotonin-producing tumor. Actually, a serotonin-producing tumor of the pancreas would be a true carcinoid in the pancreas, and that only constitutes 5% of all peanuts. So it would be most extraordinary to occur and to cause the rapid presence or development of carcinoid valve disease. Now, the other possibility would be that it was a metastasis from an existing carcinoid of the midgut or wherever, and that should be ruled out. But first, it also should be determined if it's one of the other more common types of peanuts.
All right, I have time for one more question if I can. Go ahead, Dr.
I just
Jackson.
wanted to go back and make one comment about I would advise anyone who's going to undergo, anyone with a carcinoid syndrome who's going to undergo any invasive procedure to first talk with your carcinoid doctor and get advice, because usually he or she will communicate directly with the person who's going to do the procedure who may not be familiar with carcinoid. So you want to be sure that you are protected for any invasive procedure, even dental work, as has been mentioned.
No, totally concur.
Okay. Did I say one more question? Can I sneak one in? For Dr. Odorisio, is prrt effective against lung carcinoids or only effective for GI noids?
Oh, thank you for the question. The lung carcinoids have been a little bit the stepchildren of the abdominal ones, but they are a different beast. If you ask me what percent of the carcinoids, even typical, and the typical carcinoids have the receptors, that number falls off. And that's why doing the receptors on the tissue, the answer is yes, PRRT does work. Our series, I think I showed you, it's on that table. The time to progression, though, is shorter by 3 years than it is for pancreatic and for midgut, even giving octreotide. If you look, we had a small number of those that were treated with PRRT. You have to look at the receptors because they don't have the same high percent receptors on them, even when they're a low grade or even an intermediate grade. We cannot explain it, but Granberg also said the same thing from Europe, from Sweden. I think he's from Sweden. He said that these receptors are not always on the pulmonary ones, so they're a bit tricky. And on the other hand, as Richard pointed up, everolimus now has been shown to be effective for the pulmonary carcinoids, and I think this is wonderful news, because it's behaving like a pancreatic neuroendocrine tumor with everolimus, and yet it doesn't have the high percent receptors. So in order to do that, you have to confirm, but it can be very effective, yes, with PRRT.
Okay, with that, I'm not sure if the rest of the panel wants to stay or if you guys want to stay for a few more questions, but unfortunately, if Dr. Odorisio does not get out right now, he will turn into a pumpkin, which is nothing compared to what will happen if he misses his flight, because his car is here to take him to the airport, and Dr. Sue Odorisio gets a hold of him for missing that flight. I don't want to be part of that. So I want to thank Dr. Odorisio. I want to thank our entire panel, actually, for this. This has been phenomenal.
We had 3 and now we have none. I don't like liver cleansing. I don't like supplements. Let's go to the reasons. There is no FDA control over any kind of supplementation that we have at this point, so that there's no guarantee of what somebody puts on a label in the supplemental area is going to be what's in the bottle. So with that being said, there's a lot of concerns with people taking supplements. We know that there are some of our supplements that actually interact with chemotherapies and blood thinning, and especially if you're going to go to surgery or a chance you're going to go to surgery, we definitely don't want to have those blood thinning supplements in your blood. So we stop them at least 6 weeks before. But liver cleansing is not going to get rid of these tumors. No more than colon cleansing would get rid of colon cancer tumors. This is just not going to make a difference there. They tend to be, the ones that I know of in the liver cleansing tend to be done with juicing, and juicing we already talked about contributes to a lot of the malabsorption and problems with dumping and diarrhea. And they tend to be very low in calories, and they'll put you below your calorie need for a period of time, 3 days usually in these. And we don't store protein. So every time you go on a 3-day fast, you're losing 3 days of protein. Your body doesn't hold protein. And for cancer patients, having a protein status that is high and stable is the most important part of what your treatment is. Weight, we can fluctuate a little bit, which is hard to get somebody to regain their muscle once it's lost because you have to rebuild it. You can't eat something to build muscle. You got to rebuild muscle and use some muscle. So for those reasons, I'm really not pro. But I will tell you, if you are going to do something like that, it needs to be under management, and somebody needs to be watching you, and there needs to be a real reason for why you're doing anything that you do in nutrition. Because there really are some real concerns in these areas. And most of these things, let me tell you something. These supplemental companies that do this, they're targeting patients at risk. And oncology is one of the biggest risks that we have because you're a vulnerable group, and if you could take it in a bottle and a pill and get well, you're going to do it. So they're looking for you, and they're going to try to sell you everything they have. You're not going to beat eating well, a stable diet. You're not going to beat anything with a pill that you can take in a bottle. The more research we know about supplements, and I'm not talking about vitamin A and K and E, I'm talking about the other herbals and things in those areas. There's just not enough research to say, and the American Cancer Institute research specifically says do not take supplements as the way to prevent cancer or to decrease cancer. So there is has never been a risk factor or any kind of improvement in tumors by these supplements. The few studies we have done, a vitamin A study, they had to stop because it increased lung cancer. The selenium study in prostate cancer, we had to stop because we saw an increase in prostate cancer. So I do have some real concerns in those areas. Thank you for the question.
Okay. I've got a lot more questions here. Do you folks want to stay for a few more? Yes? No? Because a bunch of people walked out, and I'm like, okay, am I taking everybody too long? I don't want to, push everything here. If some of you have to go or whatever, I understand, but I don't want to, run everything out. Let's see. Can someone switch back and forth between Octreotide and Narendra?
The answer is yes.
I like the short ones like that. Okay. If the natural focus of cancer treatment is to provide your body with a more alkaline environment, how does this impact nets? If the natural focus of cancer treatment is to provide your body a more alkaline environment, how does this impact nets?
Okay.
I guess the first part is, do you subscribe to the alkaline?
Okay, but I just say, let's start with the first part. I don't think that there's any, the body is a wonderful thing, and it has wonderful mechanisms and buffers to keep your body at a certain level, pH-wise. So to keep something at an alcohol level, and Dr. Warner, do you want to step in on this too? Dr. Warner. The alkaline studies have never been shown to be, because your kidneys and your lungs are going to compensate for it.
I think that it's very difficult in the presence of a normal body physiology to significantly change the pH. And I don't know of any proof that it's healthy to do so, or certainly that it's anti-neoplastic to do so. And I certainly wouldn't espouse doing it for neuroendocrine tumors.
Yes, that's our agreement on the nutritional end. I just wanted to hear it from, I can tell you everything I say, if I can get it back by Dr. Warner, it makes a lot more, makes it more important. So yes, I think that's a real misconception in the cancer treatment, for all cancer treatment thing.
Okay, if they recently found a carcinoid net tumor, how do we know if this is my primary?
You're asking how do you differentiate a metastasis from a primary? That's a great question because sometimes it's very difficult. We know that primary tumors don't begin in lymph nodes, for example, so that it depends in some degree on where it's found. We know that primaries don't start in certain other structures, and again, it depends where it's found. Certain areas can have metastases where you wouldn't expect the primary tumor to originate. For example, in the skin, although that there is a type of skin neuroendocrine tumor that can mimic carcinoid, but the histology is a little bit different. So much depends upon where it is and how thoroughly a search has been made for a primary somewhere else. It is true that a primary in the intestine, for example, can be very small, no bigger than a grain of rice, and may escape easy detection and may give rise to large metastases, such as in the lymph nodes, in the mesentery, or in the liver, etc. But invariably, at surgery, such lesions are disclosed.
Oops, my fault. Not James. James is pretty good, by the way. If you ever watch him, he's paying attention. He's on those buttons, boy. He doesn't miss much. All right. This was talked about quite a bit, and I think there was some conflicting stuff back and forth here. What's your viewpoint on the Ren Labs test? The Ren Labs test, your viewpoint.
Yeah, I did comment upon that, and I will do so again now. It's experimental. It does not report yes or no for whether you have a metastatic or progressing disease. It presumes to present or report on the likelihood, on the percentage of whether you have positive tumor or not, and does not give you an assurance. Some cases have been studied repeatedly within a short period of time with widely differing results. So that has weakened credence in the value of the test. But again, it's still being carried out as an experimental study, so that I would not put any serious clinical decisions for treatment based upon the Ren or NET test yet.
Okay, Nancy, I'm going to ask you this one because you worked for Dr. Coles, who's the somatostatin Swami, or Sandostatin Swami. Dr. Coles, in case you don't know, did so much research on it. Unfortunately, a lot of it was just shared among the experts, but there's stuff that we know about Sandostatin and Octreotide and whatnot that without his research and his experimentation, we really wouldn't know. But will pumps be available to make it easier for breaks from the 28-day shot and to get a better blood level than self-injections?
Pumps with regard to short-acting. Yes. We use insulin pumps in our practice for patients who don't have adequate coverage with long-acting or need rescue shots that are quite large and frequent. So we're already using insulin pumps.
Okay, I'm going to make this the last one because we do have to get out of the room by a certain time, unfortunately. And I got a couple people to thank here. You have to listen to that, by the way. Okay, Ki-67 determined from a single tumor. Does it mean all the tumors will have the same growth rate?
Absolutely not. In fact, if you take analysis from different segments of the same tumor, you'll get different reports. It simply varies with the spot in the tumor that you've analyzed it. And usually we don't take needle biopsies or assays of the Ki-67 in multiple spots in the tumor. But if we did, it would vary considerably. We have to assume that what we do get is representative, if not absolutely the same all over.
Okay, with that, I want to wrap up. I want to thank, first of all, our panel here. These folks have been great. They have given up so much of their time. It's just amazing. Every time I work with them, it's like I tell everybody, they say, well, what do I expect when I come to one of these? And the first thing I tell them is, the panel that's up here, when you go to like a concert or a conference, the people who are speaking, they sit in their little green room, they whisk them out, they do their 1-hour lecture, and they whisk them back, you never see them again. These folks, as you found out today, are trolling the hallways, willing to talk to you, okay? It's pretty amazing what they're willing to do. Reminder, if you've got a ribbon on your chair, make sure you see Cindy for your gift. I want to thank Ipsen and the Carcinoid Cancer Foundation for their support. Without this, we could not make this possible. By the way, Grace, stand up. Does anybody not know Grace Goldstein? If you call the foundation and you talk to Grace, that's Grace, by the way, just so you know that. I want to make sure you also check for your belongings when you leave. We do not have to vacate the room, so if you want to hang out a little bit and wander around, chat with one another, or whatever the case might happen to be, my only caveat is going to be please stay away from the front area, because we're going to be pulling up cables and all kinds of technical stuff and moving equipment around, and it's a real trip hazard and crazy stuff like that. One other person I definitely need to thank, Cindy, my wife. Okay? She didn't sign up for this, all right, but she's been here for it. She spent all day Thursday, 13 and a half hours putting together the handouts. So, you know, it's kind of like, okay, you know, it freed me up to do other things that needed to get done. So I have to thank her. She's really, really great. With that, again, I want to thank our panel. I want to thank everybody for coming. Have a safe trip home. If you're going home, if you're staying, that's great too. And thanks for being here. We hope you got something out of this and hope it was worth your trip. Take care now. God bless.